Assalamu alaikum, everybody. Thank you very much for joining us in our International Tumor Board with ABCDE. Today is the hematologic malignancies and bone marrow transplant. I truly appreciate Kareem for organizing the event, and of course our organizers, Dr. Munawar Hamid and Dr. Rahab Hassan, for always being there to support and provide us with cases. Today, inshallah, Dr. Munawar will be presenting, and we have a couple of challenging and very interesting cases to review. I'm in communication with Dr. Gabolla as well, as he will be hopefully joining us soon. Munawar, please, you can start.
Okay. Good evening, everyone. So case number 1 is a 61-year-old male patient was presented with night sweats and fever about 4 months ago. He is a known case of non-Hodgkin lymphoma, diffuse large B-cell stage 4, was diagnosed in 2018. He's diabetic, hypertensive, and HCV positive. He has no surgical and family history. He is a heavy and active smoker. At 2018, the condition started with hemoptysis and chest pain. CT showed there was a right lower loop bronchial mass that measured about 7 centimeters dimensions, multiple enlarged mediastinal lymph nodes, and splenic focal lesion, query infarction, query infiltration. Bronchoscopy and bronchoalveolar lavage biopsy was done and revised at our center, and it was diagnosed as the non-Hodgkin lymphoma, diffuse large B-cell, positive CD20 and LCA, and negative CK7, TTF1, synaptophysin, CD56, CD3. His lab tests, CBC, liver, kidney function, all were normal. Bone marrow aspirate and biopsy were unfit for diagnosis, but he didn't repeat it. Echo showed the ejection fraction of 56%, so our consultant preferred to give him etoposide instead of anthracycline. He received 4 cycles CIOP and had some clinical and radiological improvement as regards the size of the lung mass, mediastinal and splenic focal lesions, marked regression. He continued another cycles of CIOP, but with 2 cycles R and PET-CT in comparison to the liver ECV of 2.7, he has residual positive mediastinal lymph nodes. The largest was 2.5 centimeters, ECV was 4, plus low FDG avid right lower lobe condition at the site of the initial mass. Trial biopsy was inaccessible. So what would you do now with this mediastinal lymph nodes? Dr. Mohammed?
Okay, thank you very much, Dr. Munawar, for the presentation. I wanted to just circle back. Do we have any pathology review of this case, Dr.?
This time? No. Recently, no.
No, and the original was a clear cut, right? There was no question there.
No. It was sure non-Hodgkin diffuse large B-cells.
And
the new bone marrow is evaluated and revised by Dr. Dalia. She's with us today. But the old pathology, we had no doubt about it.
Got it. And is this bone marrow biopsy is up for review today or no?
Yeah, it's up for review, and we have bone marrow aspirate, not bone marrow biopsy, blood film and bone marrow aspirate.
Okay, maybe before we talk about the management, we can take a look at that.
Okay. The patient continued till the 6th hour, and CT was regressive course. Then a few months later, he received the radi survey on the mediastinal lymph nodes. That ended at August 2020, and PET-CT showed the stationary course as regards the metabolic activity of this mediastinal lymph node, but regression in the size. And the patient was on follow-up since then. This is a great view of his CBCs that were withdrawn from August 2021 till October 2022. As we can see here, the total leukocytic count is progressively increasing, and it's mainly neutropenia and monocytosis. At first, it was thought that it could be infection, and the patient had history of cystitis or received antibiotics, and the blood film was leukemioid reaction, but he didn't improve. On the contrary, it increased more and more. It reached even more than 100,000. Blood film initially, as I said, was leukemioid reaction, but the count increasing and increasing toxic symptoms. CT stationary course. Bone marrow aspirate was marked hypercellular. No infiltration by abnormal lymph, but Philadelphia chromosome is highly recommended. There was also myeloid hyperplasia, but the rest of the cell lines were normal. The new blood film showed the absolute basophilia and the eosinophilia, increased the granulocytes with immature forms, suggestive of query MBN for Philadelphia chromosome, JAK2, and the CALR. Okay, this is the images of the bone marrow aspirate. Dr. Dalia, are you with us?
Yeah, hi Manar, hi everyone.
Hi. Would you kindly describe what we see here? What is this?
So this is the bone marrow aspect for this patient, and it looks markedly hypercellular for age. The bone marrow is full of immature myeloid precursors, some promyelocytes, myelocytes, fewer meta, and some immature polymorph. This is what I can see on the
Aspirate?
1 minute. Yeah.
Okay. And this is the blood count.
How about blasts, Dr. Dalia? Do you see any increase in blasts on that aspirate? Is Dr. Dalia still?
Dr. Dalia?
I think, I don't know. I don't see her name on the list anymore. Okay, she's back. She's joining back. Disconnected.
Dr. Dalia, are you?
I'm sorry. Yeah, I got a call. I'm so sorry.
No problem.
I think this is the peripheral blood. Is this right?
Yeah.
This is a peripheral blood of this patient. And the first field to the left, it shows also some immature forms. There are three myelocytes and some more differentiated forms. There was one with basophil, but I cannot see it here, Manar. I think
were there any blast cells, Dr. Dalia?
I think I saw one on the peripheral, on the bone marrow, but I don't see any in the peripheral blood. If you go back to the bone marrow. Yeah, in the bone marrow there is maybe a couple of blasts, but it's not above 3%.
Okay.
So this is
suspicious of CML, and the Philadelphia chromosome was requested, and it was positive 30%, something like that.
Yeah, 28.
Okay.
This is a bone marrow biopsy report. It was also hypercellular with myeloid hyperplasia, 90% hidden by MBO. Only 5% were positive CD20 and CD117. CD3 was positive in 5% and CD79A positive in 1%. CD34 was negative. BCR able was 28.3. JAK2 was negative, and the CALR was not available. So, PET-CT done recently, no detectable metabolically active nodal or extranodal deposits, but there was marked bone marrow hyperplasia affecting the axial and the appendicular skeleton for correlation. So is any patient with history of receiving cytotoxic drugs and develop CML, do we call it therapy-related CML? Do we have a definition for it, or it could be de novo? It's just the patient fate.
And before we get into the clinical part, so was this done by molecular or was it done by FISH? And was there a karyotype? And the reason I ask about this is, and Dr. Higazi probably agrees, at the start, at the diagnosis of CML, usually what we see is something more than 80% of cells or 90% of cells are going to be positive for the fusion. 8% is a little bizarre. If this is somebody who had a fulminant myeloproliferative neoplasm, I worry that there is another driver other than the translocation, maybe another subclone that's not BCR-ABL positive, and that's why, again, do you know what if there was a karyotype or if this was done by FISH?
Karyotyping is not done.
I believe this was done by molecular tests, not by FISH.
Thank you.
But in therapy-related CML, usually there are other mutations than this BCR-ABL, right?
Yeah, there could be, and there are also the myeloproliferative neoplasm, not otherwise specified. It's also therapy-related, and it's usually negative for BCR-ABL, but it has other cytogenetics and molecular aberration.
But it's positive. It's low, but it's positive. So he's a candidate for TKI, right? Or what? Or would you do further investigations?
All right. So, Dr. Alkawaz, I know you have your comments. Usually, when Dr. Alkawaz is discussing cases like CML, he doesn't like molecular testing up front. So FISH is always the way to go. And that's when you see the very high presence of the fusion on the chromosomes. Now there was at least 2 years, 2.5 years maybe, between the end of treatment for DLBCL and the diagnosis of CML, correct?
Yeah, last cycle was in May 2019. Yeah.
Okay, so about 3 years. So it's kind of hard to think of any residual effect from the treatment to have affected any of these, but the therapy-related CML, I would like to hear from Dr. Gaballa and Dr. Emmons on their comments in regard to this entity.
Yeah, I mean, I have not personally seen it, but it's been reported, but I personally don't have experience with it.
So CML is an interesting entity because many of us are walking around with small clones of CML that never express themselves, and the biology behind how CML actually evolves seems not to be related to the same kind of abnormal genetics that occurs in patients with, for example, treatment-related MDS. It doesn't seem to be the translocation caused by chemo or radiation therapy. There's other changes and then a permissive immune system that seems to be what gives rise to the clones that eventually give rise to full-blown CML, which would be a little bit different if we're extrapolating from the previous therapy for this patient. Now, backing up to the lymphoma, do we know whether this was a germinal center or activated B lymphoma? And I assume there was looking for double hit or not, and I assume it was not a double hit lymphoma. I didn't see that in any of the history.
No, that's still, this classification is still not routinely done, you know.
I see.
BCL2 and BCL6, I think they were done. I'll get back to the pathology.
Gotcha. And what about terminal center versus activated B? I'm curious about the choice of etoposide for this person who was not that old. Was it on the basis of the diabetes? Was there concern that the hepatitis was causing liver disease? Why etoposide over standard CHOP?
Well, because the ejection fraction was 56%. Usually, we prefer
normal,
to give letrozole. Yeah,
56% is normal on this side of the.
I know, but they correlated with the age and the performance and comorbidities, and prefer to give letrozole.
I see. So is that a standard recommendation then that you often will substitute etoposide for situations like this?
Yeah. Yeah, we feel like the patient will not tolerate anthracycline, we substituted with letrozole.
So what is the cutoff for EF to use anthracycline versus not in your practice, Dr. Manor?
What?
So what is the cutoff for EF? So if EF is normal, here you would not have made any decision change. But there, when do they switch from RTOP to RCO?
From 50 to 55 is questionable. If it is above, okay, we give it if the patient is fit and well. If it is below, we prefer not to.
Okay, but this is 56.
I know.
Yeah, but I think they said there was also comorbidities and whatnot, so they decided to.
Yeah, it's based on assessing the patient as a whole, you know.
But in our institution, we don't actually, after 55, we go with anthracycline normal, no any other restrictions on the patient.
Okay.
After age of 55 or 50?
55, 55 ejection fraction. It's for us, it's normal, and we give anthracycline.
Okay. I see.
I'd say the patient was presented with dyspnea and he had PS2, and you know, this is a consultant preference.
Right. But and the reality is that the DLBCL has disappeared, at least on the PET scan, despite the activity of the myeloid neoplasm that we're dealing with now. So the PET scan is clean, but the white count is over 100,000 with lift shifted differential and 28% BCR ABL on molecular testing.
Yeah, I just wanted to finish up the discussion with the lymphoma before we go to the CML. And there are two other things to mention. The hepatitis C is associated with lymphoma transformation. Was the hepatitis C treated in this patient?
I don't have a history of that. I don't know. It's not mentioned in this record.
I would just mention the rather large literature now, the association with certain subtypes of lymphoma and hepatitis C, especially marginal zone lymphoma, but sometimes transformed larger grade lymphoma. In this country, certainly patients are recommended for therapy for hepatitis C. And in the setting of lymphoma, we would recommend that as well. Certainly not even withstand these longer term issues of hepatic cirrhosis and transformation to hepatic cancer. So is it standard in Egypt for patients to be treated with hepatitis C or not now?
Well, yeah, we had a massive treatment campaign of hepatitis C that started a few years ago. So most patients now are treated with triple antiviral, including Sovaldi.
I see. So most patients like this would be treated with curative intent. Is that correct?
Yeah.
Gotcha. Okay. And that would be an important thing. But now getting to the CML, as we said before, it's unlikely that this is connected with the lymphoma or the treatment with the lymphoma previously. It is unusual. I agree with Mo and Mustafa that it's unusual to have a lower level of BCR-ABL diagnosis, especially with such a high white count, which would indicate that there's a fairly heavy driver of the myeloid maturation here, so that you would expect to see a higher percentage, potentially depending on, this was a PCR-based assay, correct?
Yeah,
and this was a PCR-based assay done in Egypt, correct?
Yeah.
Was it done according to the European standards for PCR?
Dr. Dalia,
remember that PCR can be grossly off because of the way the animation is done. There's very careful laboratory balance that needs to be seen to get the appropriate results there. That's why, as was mentioned before, things like FISH and cytogenetics are often much more reliable for an absolute indication of where the burden of disease is, because if you're off in the interpretation of the very geometric progression of what PCR gives you, you can be off wildly in the final analysis of the percentage. Mustafa, do you want to comment on that?
Yeah, I totally agree with you. And unfortunately, I'm not sure if it's done according to the European guidelines or not.
Okay, if it's not, then I don't think we can actually rely on the percentage here. We can certainly rely on it probably being positive here, and I think it certainly fits with CML, but the absolute positivity may not be as reliable as FISH or cytogenetics.
Can I take this opportunity to ask you to send us the guidelines for Philadelphia chromosome based on PCR techniques?
Oh, sure. I mean, those are guidelines that are published by the European Consortium.
Yeah.
I can certainly point you towards the publications for that, yes.
Yes, please. And I can send it to the person in charge of molecular genetics.
There's
do you have that publication too?
Yeah, and it's not only the European Consortium. There's a reason why we report it with the international as an IS unit. It's to standardize the reporting of these across different labs internationally. But there's also another reason why we do FISH initially, is because if you really want to do a comprehensive PCR, you actually have to look at different protein sizes. So the P190, the P210, there are no PCR assays really that looks at 230, but with a very cheap FISH testing, you basically look at all these 3 breakpoints and guarantee that you're covering all of them. There is a very unlikely scenario, and it's possible, but very unlikely, is that there are multiple breakpoints and the FISH assay, the PCR assay that was performed was covering maybe only the 210 and not the 190. And the karyotype is a must regardless of whether you do FISH or PCR, because you also get to see any additional genetic lesions for prognostication.
Okay.
Yeah, and I'm so sorry. I know I joined late, but was there like a bone marrow done? I saw the
Yeah.
peripheral blood, the bone marrow. Okay, did the bone marrow morphologically look like CML?
It was apparently left-shifted myeloid without significant increase in blasts. I didn't hear whether there were increased basophils or whether there was fibrosis, but it fit otherwise for CML from the description that I heard.
Yeah, the basophils were low on the differential, so it's a chronic phase if it is.
I see. And was there like splenomegaly, anemia?
The spleen was 14 centimeters, but it had no activity on the PET-CT.
Oh, okay. Yes, I mean, there's no evidence of lymphoma, and it seems, at least from the data that we have, that it seems to be, possibly CML. It would be nice to have the FISH and cytogenetics. I'm just not sure if it would change the, the diagnosis or not. If morphologically the bone marrow looks CML, there's a little bit of splenomegaly. The FISH, we could just, the BCR ABL, we could just consider it positive without focusing much on the percentage. I think we could call it a CML and, potentially start treatment. I don't know, what would you do, Mohammed?
I was wondering, I don't have experience with therapy-related CML, and I wonder, would those be mutated? Like, should we be looking for any of what we typically don't look up front for on diagnosis in the tyrosine kinase domain mutations? Do these therapy-related come up with more acquired mutations than the general run-of-the-mill CML? that you don't look for any of the tyrosine kinase domain mutations. But as I'm just raising a question, I really don't.
No, I think it would be very interesting to look at, like, NGS and FISH for MDS panel and all that stuff. The question is, is that available in Egypt or not? I don't know.
Several issues to mention. So Mohammed raised the issue of tyrosine kinase mutations. One typically doesn't see those until patients have been exposed to significant tyrosine kinase therapy to select out clones that will be resistant, because the natural occurrence of resistant clones is extremely rare at presentation. So you wouldn't be looking for kinase mutation domain mutations at the outset. There could be other genetic abnormalities associated in this gentleman. And certainly NGS or FISH and cytogenetics should be done to look for that. And that can alter the relative prognosis and the relative expectations for response in this case. But the relative response is most importantly dictated, aside from the initial morphologic and genetics, by how well they respond, of course, with their hematologic remission less than 10% by 3 months, and the speed with which they get to full cytogenetic and then molecular 4.5.
Before we get there, Rob, what would you give them? Which TKI would you?
Kinase. So, up until fairly recently, my practice had been to give everybody in a situation like this imatinib. And for an older patient like this, I would probably still err on the side of doing this. If this was a younger person, however, given the more recent data on the speed with which one gets remission with second and third generation kinase inhibitors, and the importance of that for achieving a speedy molecular remission, and a higher chance, therefore, that patients will go on to maintain molecular remission after coming off kinase therapy when they've been in molecular remission, that is greater than MR 4.5, greater than 2 to 3 years, I tend to favor drugs like bosutinib, second generations. But in this older gentleman, and especially given the cost differential now with imatinib and other drugs, I would potentially favor doing imatinib up front for somebody like this.
I agree all with this. Imatinib?
I personally see it as a disease with less than optimal CML response, even though it's rare. Just by my review of literature on the disease, I don't have my personal experience on it. SoCal score is cool and all. It's more in clinical trials, been used a lot. Not a whole lot of clinical practice use it. But typically with intermediate or higher, you are going to a second generation TKI. So I personally would have gone with my favorite drug is bosutinib.
Okay.
Yeah, I don't have a preference really. I think, it's the differences between them. It's like, comparing the good and, the better. I mean, they're all, compared to what we had before, I think they're all okay. I think, cost effectiveness is something to consider in Egypt. If they're all the same price, sure, we could go for nilotinib or bosutinib.
All three are available, yeah.
Which are available?
All three are available.
What about the price though? Are they all the same for the patient?
Yeah, they all sponsored by environment, so by the government, so it can be given. All three options are available.
What are the options?
The options available in the first line are the imatinib and the nilotinib, first line only, and they are sponsored and by the government, and both range in the same range of thing. But the bosutinib is only offered as a second line option. These are the three TKIs that are approved in Egypt.
Then I personally will go for nilotinib if that's the case then.
Thank you, Dr. Mohammed. Dr. Mohammed is a consultant in hematology. Welcome.
I think regarding the patient's previous condition and the heart condition that he had been, I think echo should be done first, and then we should decide. But to play it safe, I think imatinib is the best option that we have, unless we have some high risk consideration, his risk score should be done, of course, only also. But regarding the age and the previous condition and the previous malignancy, I think that the imatinib might be the best option for this patient.
The age, he's young. He's only 62 years old, so that's not a problem. But I agree with you. He's status post anthracyclines, and we should look at the heart 100%. And I think it comes to dealer's choice at the end, right? At this point, there's no hard fixed evidence that one against the other.
Exactly, but regarding it's not a 62 American, it's a 62 Egyptian, and
10 years at least.
yeah.
I thought he didn't get anthracycline. Did he get anthracycline?
No.
Oh, no, he did not. That's right. He did not. You're right.
Yeah.
But we were feeling for the anthracycline previously. I'm not questioning this.
He didn't.
I'm not questioning this decision now, but a full assessment should be done, of course. But regarding the toxicity screen and the side effects, adverse event that might be expected, imatinib had by far a better, less range of adverse events regarding compared to the nilotinib.
From cardiovascular point of view, of course, you're right. It's more tolerated. It's just the response is lower, but definitely has the longer.
Exactly, and we are not aiming for TFR. If you are considering for such a patient, we are just aiming for the best response with the least side effects.
Okay, can we move to the next question? Is there any improvement in DFS or OS when we add the maintenance or alone and diffuse large B-cell?
I could take
Kabbalah is the one to answer here.
Yeah. This is my no. So maintenance rituximab has been shown to improve PFS, but not overall survival in follicular lymphoma. Okay, so follicular lymphoma, you could consider it, but with COVID and all that stuff, I have even stopped doing maintenance rituximab for all indolent lymphomas. Because the risk would outweigh the benefit. But in terms of diffuse large B-cell lymphoma, there was a randomized study, and we've shown over and over that maintenance rituximab has no role in aggressive diffuse large B-cell lymphomas. Some question, the role of maintenance in lenalidomide, potentially in older patients and things like that. At least a standard of care, here we. There's really no role for maintenance in aggressive lymphomas.
Okay, even if he didn't receive 6 hours with 6 shots?
So wait, I'm so sorry, I joined a little bit late. So what treatment he got? He got
he received 4 cycles without OR and then 2 cycles with OR. So he received
he only got 2 treatments for rituximab?
Yeah, with the chemotherapy. So
okay. I mean, that was because of the approvals and delays and all that. I mean, you could just finish off the rest of the rituximab, give him 4 more cycles, and then, yeah.
But he finished 3 years ago.
Wait a minute, 3 years ago? No, you're good.
Yeah, he received R with the shop 3 years ago, not now.
No more rituximab. Leave the guy alone.
Yeah, it's a question about the lymphoma he has.
No, so typically, and again, I'm so sorry, I joined late. I was actually trying to fix something at home and I messed it up. So that's why I forgot. But anyhow, so basically, if the aggressive lymphoma has not recurred within 2 years, the vast majority of these patients are cured at this point. So if it's been 3 years already, you could leave the guy alone and you could deal with this ML. Yeah,
of course, no role for RNA. So can bone marrow transplant be an option for this patient when he achieves the negative BCR-ABL?
So I thought you said he couldn't get an anthracycline because of his comorbidities and performance status. How do you want to take him to an allo?
How can I, what? BMT transplant?
Yeah. I thought you did not want to give him anthracycline because you were concerned about his age, comorbid conditions, all that stuff. If he couldn't even tolerate anthracycline, then, transplant is out of the question, right?
Well, he didn't try it. Maybe if he tried, they would.
Well, if he tried it, it doesn't work, he's going to die. So the transplant is not it's not a very friendly.
I don't see the benefit of the transplant. He can have a long-lasting remission on a TKI if he responds. Now, he started already, Dr. Manor?
He's about to. He's waiting for his approval. But if
Well,
the
a
patient,
month
if the
ago.
patient was fit, we see frequent cases of therapy-related AML, and always BMT is a choice for them. So that's why we thought maybe therapy-related CML could be an
I
option.
think it depends on the response, on how he responds. It's how common is therapy-related CML to make such a decision and sentence the patient to 15 or 20% mortality risk at least in the first year. I don't know how Dr. Emmons feel about this, and Dr. Al-Baghdadi.
Well, again, you're assuming this is, quote, therapy-related CML. This can be true, and unrelated, of course. And again, the genetics of CML is not driven typically by damage to chromosomes. It's not like a cross-link or a base pair mutation, things of that sort. Again, normal individuals harbor BCR-ABL clones, and the current theory is that there's actually immunologic issues that allow that clone to then express itself and expand and become full-blown CML. So it's different than the kind of, myelodysplasia, acute leukemia sort of things that we see typically anywhere 3 to 5 years, sometimes, and as much 10 years in the etoposide situation after exposure to therapy. So I don't think that's the assumption here. And if that's the case, then it would be standard chronic phase CML, which would have a very low likelihood of ever needing an allo transplant, very high likelihood of response. As to whether he would have deep enough response for long enough to be one of the lucky 50% of people who would come off kinase therapy with cure in the long run remains to be seen, but likely a relatively normal life on kinase inhibitor despite that.
Okay, I can agree also with Dr. Emmons, as currently the rule for the stem cell transplant in CML, either having an advanced phase or after the failure of all the TKIs or the multiple TKIs, or having a T5I mutation couldn't be removed or inaccessible for a T315I inhibitor. Otherwise, we are expecting well and good recovery for such a patient with a good response as we hope.
Okay, so I have a colleague that one is about this strategy of treatment-free remission. We don't practice it so often, or usually when the patient knows that you will have to draw more tests and you will have to follow up more times, you just okay, I'll stick to the treatment. Yeah. What's your practice in this situation? Do you have increasing number of patients going through treatment-free remission strategy?
Yes, again, it's about a 50% coin flip. The patients who maintain, most recent data from MD Anderson is that if you've got more than 5 years remission, you have an even higher percentage, like 80% some odd, that you're going to stay in remission long term if you come off. But if you stay off 3 years, as per the European data, you've got about a 50% chance if you've got a greater than MR 4.5 or greater than 3 years of staying in remission long term coming off kinase therapy. So what's the advantage of coming off kinase therapy? Well, in addition to the cost issues, there are a variety of side effects, GI and otherwise, and there's this real vascular issue, the intimal hyperplasia that leads to more vascular disease in the long term from long-term kinase usage that isn't been as much expressed in the literature as it probably should be. That is a long-term risk that really does increase vascular risk for people in the long run. So if you can get people off kinase therapy, it should be tried. And for the lucky, again, 50% that can, after maintaining at least 3 of as many 5 years MR 4.5, it should be done.
Well, this patient is a heavy and active smoker. Do you agree that smoking decreases the efficacy of chemo and target therapy? And what do you do with them? Do you enroll them in smoking stopping programs, or what do you do?
Well, smoking is certainly bad as far as vascular disease, which is another reason why having him on long-term, and he's a diabetic too, I think, with hypertension. So he's a male diabetic hypertension who's a smoker. He's got huge risk for vascular disease. And having him on long-term kinase therapy is only going to increase that risk. So again, if you can get this guy into an MR 4.5 for greater than 3 years, and he's got a 50% chance of maintaining that off kinase therapy, that would be definitely better for his overall risk of mortality in the long run.
Okay. So any question? Or can I move now?
I would think I do agree. You just counsel them for smoking. You stress on it, but you wouldn't change your therapy if they elect to continue to smoke. A lot of the CML patients have quite a bit of other psychosocial issues. It seems like that sometimes are problematic. It's an interesting case. Please, we meet every maybe 2 months or 3. So fill us in how things go with this one as the patient gets approved and start on therapy. It would be interesting to see.
I'll keep you posted.
Okay, so the question for you, how about the other way around? How about the secondary malignancies that was after TKI therapy for CML? We are starting to see some of these. What is your opinion about such cases? Are they have higher incidence or just still too premature to talk about this?
It's interesting. I have not seen that myself that much. We were talking just a short while ago, however, about lenalidomide and potential long-term suppression in certain lymphomas. And that literature has really matured recently. Lenalidomide is definitely a risk for transformations in secondary cancers, but I'm not convinced that we have enough information about long-term kinase use and malignancy.
Yeah.
So
I agree. I do look, we keep an eye that on any concern for malignancies, but I do practice treatment-free remission as soon as a patient is ready and able to, and that would minimize overall side effects. But I haven't seen the increased risk of malignancies in real practice.
So might be the scenario that they are living longer, or they are susceptible to have a malignancy, whatever it is, unrelated to their CML or their TKI therapy.
That may be true. That's maybe true, but I don't know if the TKI therapy is contributing. Yeah. That's a case.
I have a question regarding the detection methodology for Philadelphia or translocation 922. So if you think it would be better for the patient, or it would be like more sensitive to make it with fish. I don't know, Manar, if you double check with the lab if the fish probe is available right now and you want to just confirm with fish technique. You can do it now before treatment.
Please understand, it's not more sensitive. Sensitivity doesn't really matter for the initial diagnosis of this disease.
Or more reliable, maybe.
It's more reliable,
yeah,
exactly.
Yeah, this is what I meant.
Mustafa mentioned, yes, right, exactly. It's also cheaper and faster typically. So there's lots of
Sure, yeah. So do you think it will add a benefit, or there's no need for it?
No, I don't think it's positive 28%, so it's likely real. I would not do fish follow-ups. We follow with PCR because we're hoping that fish turns negative down the road. But on diagnosis, we don't use PCR. Fish gives us the diagnosis the same day, so we go with it.
Okay.
All right. Case number 2, 12 minutes.
I don't know how I say it in 12 minutes. Okay, this is a case of 23-year-old female patient who has just finished her second trimester, was presented with bilateral breast masses that she felt 2 months prior to seeking medical care, followed by feeling of difficulty of walking weeks after. She has no medical history. She had a history of D10 to D12, space occupying lesion, mass excision, was done at August 2022. She is married with one offspring that 22 years old in 4 months. She has done a number of investigations in private. She did post-breast ultrasound that showed that the both breasts are infiltrated by multiple related masses with echogenic components and two suspicious left axillary lymph nodes. She had a true cut biopsy from both breasts that showed the undifferentiated malignant tumor for her immunohistochemistry. Immunohistochemistry took about 3 weeks. So while she was waiting the result, she started to feel losing motor and sensory function of both lower limbs. MRI lumbar spine without contrast because gadolinium dye is teratogenic. It showed that there was the intradural extramedullary cystioccupying lesion at D10 to D12 that was compressing the distal cord and the conus. And because it was non-contrast, they were not sure. Maybe it's a subacute intradural hematoma. Also, there was the subarachnoid hemorrhage. CBC at that time showed leukocytosis. Mono was 11, lymphocytes 5.8, and the neutrophils were 6. There was the macrocytic normochromic anemia, and the platelet count was 113. Her lab functions were normal, and obstetric ultrasound showed viable fetus matched with his gestational age. She was admitted at the neuro department, and she did laminectomy and excision of the lesion that came also with malignant round cell tumor immunohistochemistry. Finally, the immunohistochemistry on the breast TrueCut was acute leukemic infiltration of both breasts, positive CD117, LCA CD34, and it was negative CKER CD3, CD20, CD79A, synaptophysin, and CD138. So she was referred to us now. She had deteriorated CBC, now increasing in the leukocytosis and cytopenia. Blood film showed 63% blasts in the peripheral blood. Luckily, she was not in tumor lysis. Bone marrow aspirate was 35% blood, normal cellular. And the flow test became AML M2. She did just translocation 821 in version 16 and 3, and they all were negative. As we looked to the flow test, it showed that it expressed the CD33, but it was DEM2 negative. So do you think she could be a candidate for gemtuzumab, and is it safe in pregnancy?
Who would like to weigh in on this one? That's a very tough case. Dr. Gaballa, I know you don't do a whole lot of acute leukemias, let alone pregnancy, but would you give us some of your wisdom on this?
No, so I mean, she's in the second trimester, and I have personally treated patients with, for example, ABCDE. There's a lot of literature on the second trimester. Inductions, however, with AML induction, I think one of my colleagues has done it, but I would need to check with it, and I'm not so sure about the literature with 7+3 in the pregnancy. But I mean, in the second trimester patients, you could give chemotherapy in the second trimester.
She's starting the third. So.
She's actually starting the third. Yeah, I mean, you could do it. The problem is you could probably, it's a really tough case. This is one of those situations where I personally would start asking a lot of other experts in the field. I could actually reach out to one of my colleagues who's been with this situation before. I personally have treated patients with second and third trimester with ABCDE, and the fetus has been perfectly healthy. But 7+3 AML inductions, I will have to check.
Yeah.
How old is she? How old is she?
How old is she? She's 23.
What is it? 33?
23.
23? Oh my God.
Yeah, with myeloid comas everywhere. So it's a very unfortunate situation. I personally, cytarabine crosses the blood placenta barrier. So it has a risk, but you are starting your third trimester. The risk is down. Using 7+3 has been reported with minimal outcomes. There are reports about cardiomyopathy with in the not just in the mother but in the fetus for those exposed to anthracycline during pregnancy. But if you don't treat the patient, both of them are dead. So Gemtuzumab is cool, but I don't think this is a case that Gemtuzumab is going to do anything if it's DIM to negative. Gemtuzumab efficacy is barely there in those strongly positive CD33. So imagine in DIM to negative, it's unlikely to do much.
Yeah.
And this is a person that is going to go, she's going to need an allo transplant, and she's likely will be infertile with what's going to happen with the allo transplant itself. So I would try to salvage the baby, but also if you want the baby to survive, I think we need to treat the leukemia as intense as we can to save both of them.
Yeah, actually, Muhammad, actually, my problem is actually not the placenta and fetus and all that stuff. I mean, I think the fetus will actually do okay, from the chemo standpoint. The question is, the induction complications and neutropenic fever and all that stuff with the pregnancy. That's really what I'm concerned about. I'm not too concerned about the chemo itself.
Yeah, I think when I reviewed the literature on this, because I had a sad case a couple of years ago. They're always sad when pregnancy and acute leukemia. Even though going for induction chemotherapy did have some increased risk with the patient, and they do typically, unfortunately, get diagnosed later because some of the symptoms might be blamed related to the pregnancy itself, the fatigue, the hemoglobin coming down, the platelet.
I have a comment. Good evening, everybody. Assalamu alaikum. Good evening. I am Dr. Noah. As regards acute leukemia in pregnancy, we have experience in Mansoura University. Even we published 2018 a small review as regard the pregnancy and acute leukemia. Almost it is similar outcome. I think for this patient, it is a life-threatening, and she has advanced and aggressive disease. So I will go for 3+7. If she is approaching the end of pregnancy, we can go for induction delivery, but I think she is still 23 weeks, as I noticed. So I think we should go straightforward for 3+7. For me, I mean, as we did, it was also small retrospective study, but it was similar outcome almost, no significant impact on outcome of acute leukemia compared to non-pregnant patients.
Yeah.
Thank you, Dr. Noha, for judgment. Let me ask you a question. How often in those who are all negative in the markers that you checked, how often do you check for the rest of the profile in order to, would you just call it a normal karyotype AML and make them an intermediate risk? Or do you do send for NGS or other myeloid exams?
Yeah, no, we do if the patient can afford.
Okay, so it's a patient expense.
But NGS is not available, yeah.
Got it.
But I think we should
you would send her for transplant based on her high risk presentation being extramedullary, or based on her negative translocations?
Both. So extramedullary myeloid sarcoma in general is a high risk for disease relapse, and it is an indication to proceed with an allo transplant once in remission. This patient, we don't have any driver here. We don't know if she has any. We know that FLT3 is negative, so there's no targetable mutation as far as we use in frontline, and we have the inversion 16 or the translocation 821. So she still fits for an intermediate risk, and those go for an allo transplant once in CR1.
Yeah, I mean, as you know, I don't see a lot of AML these days, but the ones that I, saw previously and took care of in the hospitals, usually those extramedullary, they don't do well. A lot of them get CNS, involvement later on. So typically we would also, prophylax with IT cytarabine for intrathecal cytarabine for these patients for CNS prevention. But I've personally seen a lot of these patients get CNS disease. Now, does she actually have CNS disease? I saw that she had some coda equina and stuff like that.
Yeah, there was a mass at the D1, D10 to D12, but she hasn't done a CSF analysis yet. She's planned to.
But wasn't it causing a cord compression?
What? At D10 to D12.
Right?
Yeah.
So what's the treatment? Is it radiation or what?
She did the excision of the mass. She excised the mass.
Oh, and what did it show?
It was a malignant undifferentiated tumor. It still revised the.
Oh, so the biopsy was not from the breast; it was from the.
It was both. She took biopsy from both breasts, and she took biopsy from the excised mass. The excised mass is still under revision, but probably it will be also AML.
Yeah, she's going to have CNS disease unless some miracle happens. She's not going to do well, this patient, unfortunately.
There's a broader issue to bring up in this case. Younger patients who present with the AML, we need to keep in mind now there's an evolving literature for familial genetic syndromes that lead to acute myeloid leukemia. This could affect both the patient and her child, and there is a battery of tests that are often sent off for these younger patients in this country to look for these syndromes that is an expanding list of these. So, older patients with AML, we assume are related to cumulative genetic abnormalities, but there are certainly patients with Fanconi and other issues that arise in their 20s that are related to these underlying genetic defects.
Actually, Dr. Emmons, that's an excellent point. I mean, maybe this is actually Fanconi, so we should probably test for that because they get a lot of toxicity from standard dose 7+3, and we might want to look into it.
Especially given the unusual nature of these other granulocytic sarcomas, I guess, that are popping up all over the body. This is a very bizarre genetic syndrome. And again, those are often not the garden variety kind of changes that one sees in acute leukemia. And this may arise from some other difficult underlying genetics.
Yeah, that's an excellent point.
Well,
so I wanted to ask a question. Oh, are you not done presenting, Dr. Manor?
No, please ask the question.
No, I was actually going to talk about following now. What would the rest of the panel here recommend in terms of conditioning for patients in this? I already made up my mind. She needs to go into an allo as soon as she's done with her pregnancy, and we need to keep her in remission until then. But I guess we can wait because it seems like you already have data on the follow-up.
So the patient was in the 29th week gestation. She started the first cycle, 3+7, with antibiotics, but she had mild cystitis. And the cycle was tolerated and uneventful recovery. Bone marrow evaluation after 3 weeks was in remission, 2% plus. So this is the date of the second induction. Now she's 32 weeks gestation. Do you go for the cycle now, or would you try to do delivery maybe?
So wait, I'm sorry. You said she's in remission. I mean, you
Yeah.
wouldn't.
Yeah, after the first cycle, she's in remission.
I mean, typically for those patients, we do consolidation and take them to an allo. She's 32 weeks. So when could she deliver the earliest if they could like induce her or something?
Well, obstetrics consultation, they wanted to deliver it at the 36th week, at the beginning of the 9th month.
Yeah, I mean, as Muhammad was saying, her remission is be very brief, and she's going to get all kinds. She's going to relapse extramedullary. It's going to show up on her skin and liver and brain. So the quicker you get her to an allo, the better. So the quickest they could deliver her. I mean, you could do consolidation till you get an allo, but you should identify a donor now.
Okay, so we, of course, every step we have the obstetrics opinion with us. They wanted to postpone chemo 1 month, but we couldn't agree with that. Yeah, we needed to keep her remission as long as possible. She started 2 and 5, and this is the CBC of today. Everything was going better. Breast masses decreased, the lower limb motor and sensory functions were restored. She started the HLA maxes matching process. She has only one brother, 22-year-old, diabetic, but he has no other medical condition and he is fit. He was planned for delivery in a few days, but unfortunately, a premature rupture of the membrane occurred, and the fetus was in distress. So 2 days ago, she had an urgent C-section, and the fetus died. But she's in remission. So Dr. Noha discussed this retrospective study that was done at our center. What about you? Do you think that pregnant AML carry poorer prognosis than non-pregnant AML?
Anything in pregnancy, in my opinion, malignancy-wise, is bad. I mean, it's I don't know if it's like an immunological thing, but usually any of these malignancies, breast cancer, lymphoma, they usually don't. I mean, it's if they come during pregnancy, it's usually a high risk factor.
Okay.
Yeah, my personal experience is bad. The data shows that they have similar responses. I have a patient who was acute leukemia during pregnancy and had to go through this, and she's now 30 some years post an allo. So it goes both ways. It's really, my question is, why 5+2? Is that your standard consolidation?
Well, sometimes we give 2 3-on-7 or 1 3-on-7 and 2 2-on-5.
Yeah, so
HIDAC. Oh, I'm sorry.
Actually, Muhammad, when I was in Egypt, I think I remember we were doing 7+3 and then consolidate with sometimes even another 7+3 or 7+2. But obviously in the United States here we would do 1 7+3 and then high dose RSC for consolidation, and that's usually better tolerated than the 5+2 or the 7+3. And you keep doing it once till you go for an allo. But I think that might be still the case in Egypt.
Yeah, we usually give 2 to 3 cycles anthracycline based before moving to high dose RC.
Yeah, high dose RC is actually much better tolerated than the 5+2 and 7+3. So it's I highly recommend to consider that.
Yeah, I don't see the data there for using a 7+3 again, especially in remission. What's
this was like all the old data from like decades ago with that was before the HIDAC. That used to be the standard protocol back then. You would give multiple induction therapies, but it's like it's a while ago, so that's why you haven't seen it before.
We give one cycle, only 3+7?
Only one cycle of 7+3, and then you do high DAC, high dose RSC consolidation up to 4 cycles. Or if the patient could go to, go for an allo, then you stop in the middle and go for an allo. But yeah, we don't get more than 1 7+3 here, or afterwards it's
you don't want to keep giving anthracycline. High DAC is tolerated. You're maintaining a consolidation. I'm sorry, a remission with a consolidation. So I think all the data in the United States that you will see more recently published, it will be skewed if you compare it to the Egyptian population, if the Egyptian population is receiving consolidation with anthracycline, because here that doesn't happen unless there is like a residual disease, but not high enough. They might then go to 5+2, but it's not the most common approach either. They would go to another induction or to switching gears to HMA venetoclax. So I learned something.
Okay. I think Dr. Roberts answered this question, that the fetus needs to do further genetic tests. He was born into a young AML mother. And this question, we also answered it. She should do allo. Okay.
Yeah, I think she needs the fetus needs with exposure if the baby was born, to monitor the cardiac function, make sure with a couple of cycles of exposure. I do, if I remember correctly, the anthracycline, their size is bigger, so they don't cross the placental barrier as much to the fetus, but it has been reported with cardiomyopathy in the kids, let alone the mom. But again, that's the only thing that can come to my mind aside from looking for familial disorders. And that's definitely a pediatric hemonc expertise, and Dr. Emmons covered that. Now, in terms of I'm circling back to my question with conditioning. Dr. Al-Baghdadi and Dr. Noha and Dr. Manor, Dr. Gaballa and Dr. Emmons, what do you think of a conditioning regimen for this young lady?
I think ruling out Fanconi would be important, because that can also influence the the condition. So what's the common? I mean, here in the United States, you're not going to see any consensus on conditioning regimens.
Yeah,
you're going to see centers doing, they believe in radiation, TBI. There are centers that are busulfan diehards. Flu mel, that's another regimen, but and there's not going to be usually a standard. There's usually not a standard regimen here. If you ask like 10 transplanters, you'll get like 20 answers usually.
Yeah, I'm interested in these answers.
Yeah, but I think regardless of what we do, we should definitely just make sure this is not Fanconi, because these patients will get a lot of toxicity, say if you're using standard doses like Bu-Flu or something. So you should certainly consider that. But yeah, I mean, I don't know what's the common conditioning regimens in Egypt. I don't know personally.
Yeah, what would you think of a conditioning regimen for this one?
I don't know.
So Muhammad, what would you do? Like, do you have a preference? At your center, what do you guys do?
So I talked about this, and there is no consensus. And I talked about this with a multitude of centers, like you said, because we do gather all the Arab transplanters when we meet at TCT, and we run our regular arguments that never end. But radiation seems to be a belief system in myeloid sarcoma AML. So AML with extramedullary involvement, there is a belief in a good number, almost the majority of the centers that I asked, to incorporate TBI in their conditioning regimen for those. Now, the data is not enough to support that, to say that there's any, like, that's the standard. But I would say more than 75% of the centers that I asked around were using TBI. Now, I'm thinking on our limitations with the donor situation. So there's one sibling here. So 25% of matched related. So if that's the case, I personally would go with TBI conditioning regimen, despite the data of how good is FluGu4, just because how bad is her extramedullary disease, and the TBI hope to impact it. And I have to say, this lady might need some radiation specifically to the area where the surgery was done, now that there is no baby anymore. You know, so she might, that improvement that she is enjoying right now might not last, as the regimens that she is getting are not necessarily affecting the CNS. If she's not getting any intrathecal chemo, then radiation is needed. And she would benefit from intrathecal, analysis, CSF, and then treatment, even on your analysis. But I would say TBI, if it's a condition, if it's a matched related donor, flu TBI ablative, if it's a haplo, because I think our eggs are all in one donor here, which is that brother or sister. That's our donor, no matter what the HLA shows. That donor will be either a full match or a haplo, and I would use an ablative haplo conditioning with TBI flu based on the ablative haplo data from Hopkins. That would be mine, but I didn't want to answer that until I hear from others. But I would love to hear what would our colleagues recommend. And I think, I know we're past time, so I promise that's my last question.
So several things. The first is that if there's a familial genetic syndrome, I'd be very careful about using the brother. The brother would need to be screened, of course, before being an appropriate donor, because many of these are autosomal dominant abnormalities, and the brother could certainly be affected as well. If the brother is not affected and there's no familial syndrome, a haplo versus related versus MUD still needs to be considered. Certainly a related donor would be best, but haplo versus MUD, keep in mind that the relapse rate after haplo transplants, especially for high-risk leukemia, is higher than after related donors or MUD donor transplants. Hence, if there was a fully matched unrelated donor, it would probably be favored for a high-risk leukemia, as this seems to be genetically. Mohammed's comments with regard to central nervous system is absolutely correct. As to whether TBI would necessarily decrease that risk is unclear in a myeloid situation. It might. Certainly, sampling of the central nervous system, important here. Probably directed CNS therapy, important here. Keep in mind that once the allo takes effect, it takes about 4 to 6 months for the allo effect to eventually take in the central nervous system as well, vis-a-vis prophylaxis. So you often need to continue central nervous system prophylaxis for those that have disease beyond the allo itself in high-risk situations as this.
I just want to our colleagues in Egypt to comment on the MUD. I did not mention it because I kind of know. So Dr. Manar or Dr. Nuha, can you tell us what's the current situation with unrelated donor availability? Is there programs for that?
As far as I know, it's not present.
To my knowledge, also it is not available.
That's what I thought. That's why I limited the options to an.
I see. Sorry, didn't know that.
Yeah.
I think for this patient, the best choice was to induction of delivery after the first 3+7. Yeah, and it was 32 weeks and the fetus viable. I think this was better. And also I agree for after the first anthracycle, 3+7, if the patient got remission, we should go directly for HIDAC. Yeah.
Keep in mind, as far as haplo donors, that if there's a familial syndrome, and if the brother is affected, the question would be if it's the mother or the father who's the risk profile here, because if they are both living, they also could be potential donors. I assume they're relatively young for this younger patient.
Yeah. But he might have the genetic mutation as well. The whole family, I guess, needs to be screened before making a decision.
Yeah, there's a standard battery of tests, depending on where you are in the United States, that are now sent when this is a concern. I'm not sure what the situation is in Egypt.
I would think the pediatric hematology oncology can help in that regard at the university. You know, they can guide in this because I'm sure they do these testings in Mansoura. And then if it is indeed positive, remember, it won't be, it might not be both parents. One of them might be a better choice if the brother is carrying the same disorder. Yeah. That's a sad story. Thanks for sharing the sadness, Dr. Mahar. And, hopefully, we'll at least do better from here on for her.
If there's a familial syndrome, keep in mind, of course, that the child will have been exposed to chemotherapy as well and will be at much heightened risk for secondary malignancies across the board.
Yeah. Any final thoughts before we close in today? I wanted to thank you so much, Dr. Manar, Dr. Gaballa, Dr. Alquaz, Dr. Emmons, of course, our partners, Dr. Al-Baghdadi and Dr. Noha. We appreciate all the attendees, and inshallah, we'll regroup again, and hopefully sooner than last time, and have a good rest of the day.
Thank you. Thank you so much. It was nice to meet you.
Thank you.
Bye.